Hi, thanks for tuning in to a new episode of the Doctor Podcast Show. This is our 66th episode, and we really appreciate you tuning in. And please subscribe, follow, like, and repost this episode because then we can get even more terrific guests like we have today. Our guest today is Dr. Christopher McGowan. Dr. McGowan is a board certified physician in internal medicine, gastroenterology, and also obesity medicine. That's very unique. There are very few doctors out there who are board certified in three different specialties. Dr. McGowan is an expert in a procedure called endoscopic sleeve gastroplasty, which is done for people who are obese or severely obese. And as you know, there's an obesity epidemic going on in the USA and in other parts of the world. And Dr. McGowan is an expert in that, and we'll be discussing that. Dr. McGowan is based in Cary, North Carolina, as well as in Atlanta, Georgia. And if you want to find out more information about him, you can go to his website, which is trueyouweightloss.com. And I'll have that on the screen so you'll be able to do that. Thanks very much for coming today, Christopher. I really appreciate you taking the time from your busy schedule to join us.
Yeah, it's my pleasure. Thanks for the great introduction. And I think we're going to have a really nice conversation. So thanks for having me.
Great. So tell us how you became interested in obesity medicine after being both an internist and a gastroenterologist.
Yeah, so it's not a typical path for a gastroenterologist, at least when I made that transition. These days, it's a little more common to find a gastroenterologist who's also treating obesity. And that's because of the development of the field of endoscopic bariatrics. And that's really what drew me to the treatment of obesity. When I came out of fellowship, this field really was in its very infancy, early infancy. And as I started getting into learning about the procedures that were coming online, how we could treat obesity through endoscopic tools, and then really got a taste of actually treating obesity, I was pretty hooked. And so over the years, I then pivoted my entire practice towards treating obesity exclusively with these endoscopic techniques. And ultimately, obesity is really it underpins almost all health conditions. So by treating obesity, we're treating those conditions at the root.
Right, very important, and we'll discuss that some more. So what's the true definition of being overweight, obese, or severely obese? I know the CDC breaks down obesity and severe obesity. What is the strict definition of those and being overweight?
Yeah, so I think it's a good idea to establish some terminology when we're discussing the condition of obesity. And there are different terms that are out there. Strictly speaking, we're using BMI classification to determine these categories. And overweight is also defined or called pre-obesity. And that would be a BMI between 25 and 29.9. Anything above that, 30 and above, would be considered obese. Now, there's a category of severe obese, which is used, that's akin to a BMI of 40 and above, but we're more commonly using classes of obesity. So class 1, class 2, and class 3 would be a BMI of 30, 35, or 40 and above. But
Could you,
hmm?
yeah, go ahead. Sorry.
These are important when we're looking at populations. So you mentioned the CDC. They just recently released their updated obesity maps for the United States, and we see what a true epidemic it is. They're also important for research studies. But beyond that, patients don't really care about them, and they're not relevant to the individual, which is maybe a whole different discussion. But it is important that we look at these criteria when discussing procedures as well.
Right. You mentioned BMI several times, which is how we measure this. Could you explain what BMI is and what the different numbers are?
Yeah, so it is a simple calculation based on height and weight. It's kilograms divided by meters squared. This was developed many, many, many years ago as a metric to assess obesity on the scale, population scale. And it is decent at that when we're categorizing large cohorts. But again, on the individual level, when speaking to patients, when a patient's considering their own situation, not really that accurate or reflective of their own health. But that's how it is calculated.
Right. So in other words, if somebody's 5'7" and weighs 300 pounds, they have a huge, very high elevated BMI. On the other hand, if they're a basketball player who's 6'8" and weighs 300 pounds, their BMI might be much lower and might be in a normal range because they're extremely tall.
That's exactly right. We saw this recently with the Olympics, and there are a fair number of Olympians who are would be classified as pre-obese or obese or having obesity, yet they're in peak physical condition. So that this does not reflect body composition, muscle mass, fat mass. There's really no reflection of that.
Right. Notice weightlifters in the Olympics and the people who throw the discus and other sports like that, the hammer throw, look like they're kind of overweight, but obviously they're in good physical shape as well. So we have to differentiate that. Now, the CDC says there's about 100 million adults in the USA who are obese. That's almost a third of the population. It's a huge number. And about 22 million adults, or 9%, have severe obesity, and it's rising. Why is obesity increasing in incidence so much over recent years, especially? What's going on?
Yeah, what is going on? This is a complex question, and these are big numbers. And the estimate, the prediction is that roughly half of the U.S. adult population will have obesity in the coming years, in the next few years, really. So those are staggering numbers. And why is this occurring? It's been a very rapid rise. There are many theories, and there are many variables and factors that contribute to this. We didn't change genetically in the past several decades, right?
Right.
But
Right.
there's a genetic basis for this. There's a genetic propensity. We are designed, we are built, we have evolved to retain and gain weight for survival. And some of us more so than others, and that accounts for some of the difference, the variability amongst all of us. But when you then alter the environment in certain ways, you have more calorically dense food, fast food, sugar sweetened beverages, less physical activity. You, the environment has changed drastically, and then that genetic propensity to gain weight is amplified. So that's probably what we're dealing with. And there's other factors that aren't yet defined, but all of this has led to a rapid rise in obesity.
Seems like the foods we're eating are more addictive. If you combine sugar, salt, and fat, that becomes an addiction, it seems to me, and people can't stop eating that.
Well, they're more stimulating to those receptors in our brain that crave those flavors. And so that is a definite part of this. And there's ready access to these calorically dense foods. So that's certainly a part of this. Now, those are the components that lead to the development of obesity. But then there's the other component, which is how to treat obesity once it is established. That is a different conversation because changing diet alone isn't likely to change the presence of obesity.
Right. I'm an ophthalmologist. I have many patients who are obese, and they're constantly complaining to me that the diet and exercise thing doesn't work. So I'm glad we have you here today to discuss other options that do work. Now, you mentioned earlier that obesity is the basis for many medical problems. There's increased risk of diabetes, increased risk of cancer, increased risk of heart attack, strokes, and many other horrible medical conditions. How does obesity do that? Can you explain that?
Yeah, so it really is the root of hundreds of health conditions. You've listed many of the obvious ones, but there are many more. Really, every single system within the body can be impacted, and through various mechanisms. Just carrying excess weight has certain, of course, strains on the body that's pro-inflammatory. And once you're in the class of obesity, there are just all of these downstream impacts. And that's what our patients relate to us, just how they feel day in and day out. And of course, they can develop health conditions and they want to reverse those through an effective treatment. But it's also just how they feel every day. And that's the quality of life component that isn't addressed in these different disease processes, but it shouldn't be ignored.
Right, very important, the psychological component. Now, since we know that this is a bad condition that leads to lots of medical problems, why is it that I'm seeing more of the media and the entertainment industry glamorizing obesity in the last few years? It seems like they shouldn't be doing that. It's almost like advertising cigarettes again on TV. What's your opinion on that?
Well, I think there's been some recent movement towards body positivity, and I don't think that's a bad thing because the view historically of obesity has been 100% negative. And I don't think it's a bad thing to have some positivity. But my view is that there's still way too much glamorizing of the cosmetic components of weight loss, especially right now when we're looking at the medications that have come online in the past few years and the sensationalized weight loss, celebrities dropping significant weight. And it's focused always on the visual and the cosmetic. And I still think that has a very negative impact on people who are dealing with their own weight concerns and trying to lose weight. And I think that's still the wrong message because really this is about health and about how you feel and about way more than just how you look.
Right. So you mentioned those medications like Ozempic, Wegovy, Mounjaro, Zepbound. Those drugs don't work for everyone. I have patients who've had some bad side effects from them. And what should people do if they're not good candidates for those drugs or have had side effects? In the past 15, 20 years, there's been talk of weight loss through bariatric surgery. Can you tell us what that is and how it works and what are the indications for having that?
Certainly. Yeah. So, well, if we talk about the medications first, let's acknowledge, yes, they are way more effective than anything we had before. They definitely breakthroughs in that regard, but they are not universally effective. And that's another downside of the way that patients are receiving information. Everything is positive. These are miraculous. They are
Yeah,
a panacea. But of course, that's not the case. And if you look at clinical trials, between 20 and 30% of patients in a clinical trial, best case scenario, will lose less than 10% of their body weight. So they would be suboptimal responders. Those numbers are significantly higher in the real world. We saw a study just last week come out from Cleveland Clinic, which looked at kind of a 1 year snapshot of a very large cohort on these medications, and the average weight loss was closer to 5%. Now that accounts for inability to access it, tolerate it, stay on it, all of those factors we see in the real world, but that's the real world. So we know
right.
that these are not going to work for everyone, and there are side effects and many barriers. So then what can patients do if they're not a candidate or not responding well? So you mentioned surgery. Surgery historically, and actually to this day, is still the most effective treatment for obesity. And we're talking about traditional bariatric surgery, like the sleeve gastrectomy, like a Roux-en-Y gastric bypass. These are still the most effective and proven by far. They have decades of data behind them.
Right.
That
So
could be
they
a next
work.
step for patients. They absolutely work. The issue is that most patients don't want surgery. And so that is why it's important that better medications developed. And that's why the field in which I specialize of endoscopic treatments is important because it offers other pathways that are less scary to patients.
Right. And those surgeries, the traditional bariatric surgeries, do have some risks. I've had some patients who've had complications from them, sometimes very serious. So they're not for everybody. So tell us about your endoscopic sleeve gastroplasty, or I'll call it ESG to
Mhm.
make it quicker. Tell us about the history of that procedure and how it came along and how it's different than the traditional bariatric surgeries.
Yeah, so the ESG procedure feels really new because most people have never heard about it, but it's been in development for well more than a decade. The first iterations of this procedure were over 10 years ago, and it has evolved in the platform, the devices that we use, as well as technique. The first obstacle was finding an endoscopic technology device that could allow for full thickness suturing. If we're suturing the stomach, we have to suture it robustly. It's a very strong organ. So that was step one, and that is the current standard platform that we use, which is the Apollo overstitch device. That's been in routine use for quite a few years now. I started in this field around 7 to 8 years ago. And this is now the most effective non-surgical procedure. And we consider it non-surgical because there are no external incisions. We're not cutting into the abdomen. Everything is performed through the mouth. That's what really changes the game here in terms of recovery and risk. But this is now routinely performed in the United States and worldwide, though still limited to expert centers.
Right. So you're passing a tube down from the mouth into the stomach. Is that what you're doing?
Yeah, essentially. So we're using a flexible endoscope. This is just like we would use to evaluate for peptic ulcer disease, to look to screen for Barrett's esophagus. But on the end of the scope is a suturing device. It's a curved needle, essentially. And so we're able to drive that down into the stomach and suture the stomach from within. We're folding, plicating, and sewing the stomach into a sleeve-like shape from within. So we're able to achieve a 70 to 80% reduction in stomach volume, but from
Wow,
within.
that's huge.
So it's a big reduction in volume. It also alters the motility of the stomach. So we're slowing down stomach emptying. So you have patients experience smaller capacity, but also increased satiety and satiation. And so they lose weight over time. It's portion control. But delivering it endoscopically just means that the risk is significantly less. So we're looking at an average risk profile of around, if you look at all studies, 1 to 2%. It's lower in high volume centers. That's significantly lower than traditional bariatric surgery. And then recovery is usually a few days. Patients are back at work. They can have a procedure Friday and be back in action Monday. I mean, that's a big deal.
That is huge. Now, what you're doing here is just basically shrinking the size of the stomach, you said by 70, 80%. So patients can't eat as much because their stomach gets filled. And also, once their stomach is full, they don't have that hunger sensation. Is that how it works?
That's exactly right. So this is a restrictive procedure. There's no change in absorption. We are helping with portion control, and we're always combining that with nutrition counseling and support and aftercare. And it's so important. But what we're doing is disrupting those pathways that are so effective at promoting weight regain for someone who's simply dieting. Because patients will say, well, why don't I just follow the diet? I don't need the
Right.
procedure. And we know that doesn't work because,
Yeah.
well, diets and exercise don't work alone because the body's too effective at putting the weight back on. But when you have a procedure like this, it does disrupt and calm down a lot of those pathways. So patients have to put in the same work, but they find that it's much more effective. And that's why this is also proven via randomized controlled studies.
Right. So you mentioned there are centers that specialize in ESG, and you've been doing it now for 7 or 8 years. You mentioned. How many cases have you done, and how often do you do this procedure?
Yeah, so I only specialize in endoscopic bariatrics, and the endoscopic sleeve is my most common procedure. So that's most patients that I see are having that procedure. I've treated, and in our program, we've treated more than 3,000 patients with the
Wow.
ESG procedure over the past 5+ years. So that is a high volume center. We've learned a lot along the way from a technical standpoint. We've really advanced the techniques. I helped to standardize it along with other centers in the field. We have a good understanding of the factors that contribute to patient success. And again, it's not just the technique, though the technique matters, but it's also that aftercare and support. And then we've also seen the risk profile, which again is very favorable. So in our program, it is around 0.1%. So as far as
Wow.
any complications. So these are exceedingly rare. Things can happen, and we counsel patients about that, but it's less. If something were to happen, it's less the chance of something catastrophic like a traditional surgery is much less so.
Right. So just comparing that to the older traditional bariatric surgery, what's the incidence of serious complications there approximately?
Yeah. So that's also going to depend on center and the studies that you look at, and also the severity of the adverse events. So serious adverse events are going to be in the low percentage, up to 10%, depending on the surgery and center. If you look at a Roux-en-Y gastric bypass, that's going to have the highest adverse event rate. But then there are the less severe things, as well as the longer term complications. So for instance, with a sleeve gastrectomy, the incidence of significant acid reflux, GERD, is about 30%. And that's a big deal. So patients, and that can occur years down the line, and it can require a surgical revision. So that's a big number. So we know that the overall rate is up to 1 in 3 of a complication.
So it's much higher. So this is a low risk procedure. That's great. Now, can any bariatric surgeon do this or gastroenterologist, or do you need special training to do this procedure?
Yeah, and that's one of the reasons that there are only really, I'd say, less than 10 true expert centers in the United States. It's a definite skill. It is very different than what we typically do in gastroenterology, and it takes a great deal of training. Now, there are surgeons and there are gastroenterologists who perform this. The problem right now in the field, it remains that there's really a lack of a true training pathway. So it's one of the things we're working on right now, how to formalize the training, the standardized credentialing, because there isn't even when I started in this 8 years ago, it doesn't look vastly different right now. So you kind of have to learn on your own. There are only a few fellowship programs that teach these techniques directly, but they are very technical. And so, yeah, it's not just that someone can pick up a device and perform this procedure, but there's the other element, which is managing patients with obesity. And this, when I speak to physicians who are interested in the field, I really emphasize the fact that we aren't just performing a procedure. We're treating patients with obesity, and that's the other component, at least for gastroenterologists, that is typically lacking. And so we need to really build up that curriculum as well as that cognitive component.
Right. Sounds like they should create more fellowship programs so that people become real experts and get better results with lower risk profile.
That would be the long-term goal and plan. There are some barriers to that right now, which is just the overall procedural volume at academic centers is a little bit lower for a variety of reasons, mainly reimbursement and insurance coverage, which are still not in
Mhm.
place with the endoscopic sleeve. That is still probably a couple years away.
Right. Now, is this procedure done in your office or an ambulatory surgery center or a hospital? Where is it done?
Yeah, so personally, I treat patients almost exclusively in an ambulatory surgery center, so an outpatient facility. And there are programs that treat patients within a hospital setting, but this is a same-day procedure universally. And so patients come in, they have the procedure, which takes about 45 minutes on average, and then they can go home afterwards. And then in my program, we see them back the day after. We make sure they're recovering well. We give them some extra IV fluid to help with that early risk of dehydration. And then again, they're back in action within a couple of days typically. So that part is seemingly easy in comparison to the next year when we then focus on the real work, which is getting the weight off and then reaching maintenance phase.
Right. What kind of anesthesia do you use for this? Is it mild
It's
sedation or severe sedation?
Well, we have to protect the airway because we are working endoscopically. So it is general anesthesia, but we try to minimize medications. We use propofol. We do not use any opiate medications for during or after the procedure in our program. That's really important because there is no somatic type pain. With this, we try to really minimize things, but it's just propofol.
I see. That's great. That's what I use when I do cataract surgery. It's a great drug, works very well, and a very quick recovery from the sedation. What are the indications for ESG? If somebody comes to you and they're severely obese, how do you decide whether to do ESG or put them on one of the drugs or maybe refer them to a general surgeon for bariatric surgery? How do you
Yeah.
differentiate patients?
Well, so there are specific indications for the procedure. So this is an FDA authorized procedure. This is for adults with a body mass index between 30 and 50. Now we can treat outside of those bounds, and there are patients who have come to me with a BMI above 80 who don't have other options. They don't have insurance coverage or qualify for surgery. What else are they going to do? So this can still be effective in improving health, but 30 to 50 is the FDA indication. But the bigger question is what's best for the patient that I'm speaking to? And that's not a BMI question or determination. So patients are self-selecting, of course, when they come to see us at my practice. They're interested in the endoscopic treatments, but they might also be interested in medications. So we'll have that discussion. And there's a branch point between medications and a procedure. It's a pretty clear one. Are you comfortable taking a medication long term? And when we say long term, we mean indefinitely. That's a
Right.
really important consideration. Or are you more interested in a procedure that is a one-time intervention that has a multi-year impact? And that's an important discussion. Truthfully, patients I'm seeing these days almost universally have tried medications in some way. That's who we're seeing these days. They have tried and they have not succeeded, and they're looking at something that will be more definitive.
I see. And how long does this procedure last? Is it indefinite that the stomach stays small, or does the stomach eventually kind of stretch out over a few years and the same problem recurs?
Yeah, so that's a really common question we get from patients as well. What I tell every patient is no procedure for weight is permanent.
Mm.
None. You look at the most involved invasive procedures, a Roux-en-Y bypass, we know that weight recurrence happens, and that's just the nature of obesity. So really, we want to know what's the impact of the procedure? It's not just about the stomach itself, but we know there's a multi-year impact. So we have studies out of my program, 3 years of sustained weight loss, north of 20% of body weight. There are
Wow, that's great.
5-year studies showing durability of weight loss, some very small studies beyond that. But this is clearly a 3 to 5+ year impact. Then there's going to be some divergence on the individual level. We have patients who will maintain beyond that. Some patients will experience weight recurrence. That is the nature of obesity. So we really want to just be proactive. If that occurs, we want to meet with our patients and see how we can intervene.
Right. Is the reason that it eventually doesn't work is the stomach stretching out, or is there some other cause?
Many factors. So there's definitely adaptation that occurs. So the stomach may not even enlarge drastically. We see this with a sleeve gastrectomy. So we are able to endoscopically revise a surgical sleeve. It's one of the procedures that I perform. So patients will come to us and say, well, I've regained weight. I can eat much more than I used to. This must have stretched out completely. And then we do an endoscopy, and actually, no, it's probably about similar to where it was, but the body has adapted to that smaller size. And so that's one factor. Now, with a gastric bypass, things can actually physically stretch. The anastomosis between the pouch and the small intestine can actually dilate over time. That is a contributor to weight recurrence. But then there's just other factors. There's life. There's, everything you could imagine where things
Right.
can just slowly shift off track.
Right. So you mentioned you can get up to about a 20% weight loss. So if somebody weighs like 400 pounds, you mentioned a huge BMI, they
Mhm.
can lose huge amounts of weight with this procedure. Is that right?
Yeah, the weight loss is significant. So if you look at meta-analyses of all ESG studies, the average weight loss at a year to 18 months is around 17% of body weight. Our numbers were a little bit higher. You're going to see some differences between programs, but anything above 10% of body weight is going to improve health. We're seeing roughly twice that with this procedure. Of course, you're going to have your outliers and your patients who lose 30, 40, 50% of their body weight. But an important metric that we showed in one of our studies of ESG is that 97% of patients in this cohort of 400 plus patients lost at least 10% of their body weight. That's a big deal. That
Yeah.
is much greater than we see with the current medications in terms of overall response. And so we're improving health by achieving those numbers.
Yeah, that's great. Is there an age limit for this? As you know, there's now obesity epidemic in young kids and adolescents, even down to 10 years old and younger. Can you
Mhm.
do this on children, or is there an age limit?
Well, the FDA authorization is for adults, so that would be 21 and above. This procedure has been performed in adolescents in other countries in particular, and that's been demonstrated to be effective. I do not treat adolescents in my own practice. It is definitely a more complex population, but it can be performed safely.
And what ab- what about success stories? Do you have any recent patients that you've treated who've had incredible success and it's changed their life?
Yeah, I mean that's the best part of this job. This is why I
Right.
love this field. There are innumerable success stories that I could think of. We think of the most dramatic. There's a patient who reached out to our team recently. He's lost over 300 pounds with an endoscopic sleeve. Now that's he's an outlier, okay, but it's something to
What
celebrate.
did he start with? What did he weigh?
Yeah, he was close to 500 pounds to begin with. But what a dramatic weight loss and improvement in health and he's a younger gentleman, so just his overall quality of life. That's an extreme example, but
Right.
one that stands out. I actually like the more day-to-day victories, the smaller successes. There's actually a patient earlier today who emailed my team and I and shared that she had a major, what we call a non-scale victory. She took her family to an amusement park over the weekend and she rode a roller coaster. And she was terrified because 3 years ago, she shared that she tried to and couldn't properly get buckled in, which is horribly embarrassing. And what a
Yeah.
victory that she was able to do that. And I love that she shared that. That's one of the really nice things about treating patients longitudinally and long term as you get these updates and stories. But that the similar story would be the seatbelt extender on an airplane. Like what a just
Hmm.
terribly difficult scenario when you have to request that. And so our patients who have been liberated from the seatbelt extender, huge victory. So I love that. And then uh, there's a lot of orthopedic stories, patients who are told they need knee replacements, joint replacements, and they lose weight and they're like free and running and feeling fantastic. I love that. And then, of course, the health improvements, not
Right.
having diabetes anymore. That's a big one. Getting off of medications, not needing your CPAP anymore because you no longer have sleep apnea. I mean, these are just incredible health victories.
Sounds like we could go on for hours, and there's huge psychological benefits from this as well. Just feeling much better.
Yeah, it's so true. When I meet with a patient, the first thing that I like to discuss is just what are your goals? What are you hoping to achieve? Very few people say, I want to lower my BMI to 25.5 or whatever. They say, I just want to feel better about myself. This isn't me. I just don't feel confident. And that's really what it's about. And experiencing that joy along with patients is incredibly rewarding.
Right. That's great. Now, you mentioned you've had patients who are no longer diabetic after the ESG procedure. Is that right?
Yeah, and that is reflective of that greater than 10% weight loss, and in this case, quite a bit higher. So if you look at studies, published studies and clinical trials, around two-thirds of patients will experience improvement or remission of diabetes. So we see that firsthand. It's one of the earlier conditions to improve after this procedure. So patients will usually pretty rapidly decrease their medication requirements, decrease insulin if they're on it, which is great because just eliminating insulin, we see a further improvement in weight. And the other that improves quite rapidly is sleep apnea because of a lot of people tend to lose weight from top down. So we see pretty early improvements in that.
Wow, that's great. You mentioned earlier about insurance. Is ESG covered by insurance or Medicare, or it's not?
It is not, and that is the
Hmm.
single greatest barrier to access. So one is availability of an expert center. Two is probably awareness, actually. But the largest one is insurance coverage. So there is not yet a CPT code for the ESG procedure. So there isn't really a billing pathway at this time. That is in the works. It's been a many-year process. It took a randomized controlled trial to then get FDA approval, and now leading to a CPT code, hopefully in the near future. And then we'll see greater momentum. But right now it is self-pay.
So people have to pay out of pocket.
Yes.
That, yeah, that kind of doesn't make sense because the FDA approved it. We know that it gets rid of all these horrible diseases like diabetes and other risks. So the insurance companies and Medicare would actually save money if they paid for this procedure because then they wouldn't be treating all these chronic illnesses that consume billions of dollars in
Yeah.
insurance and Medicare.
That's right. And we've looked at this, and ESG is highly cost effective. In fact, uh, significantly more cost effective than the newer weight loss medications, which also are not universally covered by insurance, but there is some coverage in place. But when you look at the endoscopic sleeve, it's wildly cost effective when you compare it to lifestyle modification or to semaglutide, for instance.
Right. Are there different companies that make the equipment for this procedure? You mentioned one earlier, Apollo. Is
Mhm.
that the only company, or are there a few companies that make the actual technology and equipment?
Yeah, there are different platforms that are coming online. And so we're seeing further iterations and evolution of the suturing device. We're seeing robotics starting to enter the field. And so, from a technical standpoint, we're only going to see improvement. And then we're adding different elements and components to these procedures. So, in our program, we have multiple ongoing studies looking at not just suturing the stomach, but also ablating the mucosa to have a hormonal and metabolic effect. We also have studies. Looking at small bowel intervention to also have metabolic effects. So we're going to see greater progress in the endoscopic realm to really mimic those more invasive surgeries.
Right. Now, you mentioned that you're suturing the stomach. Is there a risk of hitting a blood vessel in the stomach and getting bleeding?
Yeah, there are definitely risks. And this is why the training is so important, why expertise matters. We feel safe when we're within the stomach endoscopically, but there are things around the stomach. Surgeons are aware of this. Us
Right.
gastroenterologists aren't as aware of it until we start doing procedures like this. So yes, you could get into trouble, and so you could hit blood vessels. That's not the biggest deal because we're suturing the stomach. It stops any kind of bleeding, but there are structures adjacent to the stomach. So we do have to be really careful. But when carefully performed, when you have a really good understanding of the technique, it's incredibly safe. But yes, there are definitely risks.
Yeah, you mentioned about clinical trials and research. Are you involved in any of that?
Yeah, yeah. So in my program, we have a research division, and we're actively engaged in research. This field is advancing so rapidly, and we're excited to contribute to it. And I had mentioned some of those territories we're kind of branching into and delving into. So there is a lot more to come with endoscopic bariatrics, and we're innovating ways to further boost weight loss. We really want to ultimately not just exceed the weight loss achieved with medications. We want to really match surgical level weight loss, and that's been the one when we compare endoscopic with surgical, the weight loss is not quite to the surgical level because it's not as drastic. We're still at these
Right.
are very significant numbers, but we really want to push the envelope to get to the surgical level because what we know is patients don't want surgery and they want the weight loss outcomes, and in many cases need that. So we're really trying to match that through these different modalities.
Seems like it's evolving to that level, which will be great. Now, we mentioned at the beginning of our talk that exercise and diet just don't seem to work for most people. Do you find that once people lose a lot of weight from this ESG procedure, they go back to exercise and start doing that because they simply weigh less and it's easier to exercise?
Yeah. So when I meet with a patient before a procedure, we want to establish the priorities. So number one is nutrition by far. Weight loss is ultimately driven by nutrition, by caloric restriction. That is the most important thing. Some patients feel a lot of pressure, like, oh, I really need to be hitting the gym. I hate the gym, but I feel like I must go there.
Right.
And I will usually tell patients, just don't worry about it. We're going to focus on nutrition. And then any activity that we can add in is going to only amplify the effects. And what will often happen is patients will lose weight and they'll feel better. I mean, when your knees feel better and you're not in pain walking
Yeah.
upstairs or doing any physical activity, suddenly it's more enjoyable. So that is true, like you've mentioned, and then patients will be able to build on that. And then the primary reason we will stress physical activity is not necessarily to drive further weight loss. It is to preserve lean muscle. It's very, very important. It's something that has actually received a lot of attention with the newer weight loss medicines because there is a concern about loss of lean muscle. And that's something we don't want. So for our patients who are losing weight, we're going to encourage resistance training to preserve that muscle. That's going to do a lot of things. It's important for health. It's important for metabolism so that when they do lose the weight, they can maintain it. So we want to encourage it. But what I don't want is a patient to feel defeated if, again, they just don't like going to the gym. Well, we'll
Right.
find other things that they can do.
That sounds great. Now, you're based in North Carolina and in Georgia. What do people do if they're in California or Seattle? How do they find an experienced surgeon like you and a good
Mhm.
center?
Yeah, so as I mentioned, there are definitely other centers of excellence in the country. Finding them, there isn't a direct path necessarily, but there are ways. So I mentioned the one, so the FDA authorized platform that we use is the Apollo device, and the Apollo ESG procedure has a website, from the manufacturer, and they do have a physician directory. So that is a
Oh, okay.
starting point. Now, that's not going to tell you how experienced the provider is or anything else. So what I always encourage patients to do is meet with a provider, speak to them. You want to know how many patients they've treated. Do they track their weight loss outcomes, their complication rates, things that are pretty important when you're evaluating any provider, but especially in this one because it is a very unique procedure, and the results will depend on the technique.
Right.
It is also a procedure that is you can travel basically to have this procedure. So someone who is in California but wants to fly up to Seattle to see an expert, that's okay because the recovery is so short. So we do see many patients who are traveling to these expert centers.
So you get patients from around the country coming to you.
Yeah, so you're certainly from around the country or beyond to come for the procedure. And usually we're looking at a couple days stay in the area and then they can return home safely. So for some patients, that is definitely a path. For others, it will be a matter of finding someone who's closer to home. And the good news is more and more centers are coming online and offering this procedure. So it's easier to find someone, but it is important to do your homework.
Right. So you mentioned you've done about 3,000 procedures or so. How many procedures do you think a doctor should have done in order to make them really good at doing
Yeah.
this with a reduced risk profile?
Certainly. And of course, we all have to start somewhere.
Right.
And we all have our early patients. We know from studies that efficiency of the technique is reached in about 50 cases or so. That's not mastery. You know, from learning any procedure in medicine, it
Right.
takes hundreds and hundreds of cases. I would say to really reach mastery is in the several hundred ESG procedures. And it's not just mastery of the technique. Again, it's also understanding a patient's weight loss trajectory after having this procedure and what that looks like. And you have to treat a lot of patients to understand what those averages are, what the expectations are, what the recovery is like. So, but I would put it in the hundreds, definitely.
It's good to know. So patients should ask the doctor before they have the procedure done. Any
Exactly.
Yeah. Anything else you want to tell us about ESG, which sounds like a great procedure for many patients, or obesity or your practice?
Yeah, well, the big thing here is that we have these tools available, and most patients have never heard about them. So,
Right.
of course, our patients who have procedures are talking to their friends and family, and the word is spreading. But patients at this point, so years ago it was, well, I can diet and exercise or have surgery. Now the general thinking is, well, there's medications, and after that, there's nothing else. But actually, there are so many options. So we have the endoscopic sleeve. We have other endoscopic bariatric therapies that are also minimally invasive. So there are a lot of options. So really, it's a matter of meeting with a specialist, talking through those, and maybe for one individual, it's going to be medications. For the next, it's this. For the next, it's surgery, which is, again, still the most proven. So we want to really match the procedure or the intervention with the patient's comfort level and goals and what they're trying to achieve. But there are so many options as a field, and I'm speaking of the obesity field. We're in a much different place than we were just a few years ago.
That's great to know. This has been very informative and educational for me. I'm going to definitely mention this to my patients who are having problems losing weight and have tried various things that aren't working well. So that's great to know. And I'm sure the audience out there is happy to hear about this because there are alternatives. So that's great to know. I want to thank you for taking the time from your schedule to join us today and tell us all about ESG and obesity. Thanks very much.
Thanks so much for having me.